start now. Good afternoon, everyone. Myself, Dr. Shalini Goyal, Secretary, North Delhi IAP. I welcome you all for today's meeting. Today we have Dr. Satish Agrawal with us. He is a professor and head of the department in Sir Gangaram Hospital. He is in pediatric surgery, and he is basically talking about approach of abdominal masses in children. How to approach children with abdominal masses. Good afternoon, everyone. Myself, Dr. Shalini. Okay, sir, over to you, sir.
Okay, thank you, Dr. Shalini, and thank you, the Pediatric Association, the North Delhi IAP, for giving me this chance to interact with you all. I know this is Corona time, and therefore we are all forced to go digital. But the topic that we have chosen today, when Manas suggested me that I have to speak to pediatricians of North Delhi, so we thought that I think abdominal masses will be quite an appropriate topic because as a referral center, we keep seeing patients coming to us, of course, through pediatricians, sometimes through general physicians, sometimes on their own. But many a time, several things that we have noticed, I'll highlight during the course of my talk. So I work here at Sir Gangaram Hospital, and we have a very strong team which deal with abdominal masses, thoracic masses, in fact, masses anywhere in the body, because we have very close collaboration with the pediatric hemato-oncology team led by Dr. Anupam Sasdev and very ably handled by Manas Kalra and his entire team of fellows and all. We also have very good PICU support and all endoscopic support and cardiac surgery support and anesthesia support to deal with very complex situations also. And that's the advantage of us of being in a tertiary care center where you can provide the best of the care to even the most complex problems. So is the screen visible?
Yes, sir.
Yes, sir, it's visible.
Right. So maybe I will run it like this so that you can see the cursor also. Are you able to see the cursor?
Yes, sir. Right
Yes,
now
sir.
we are able to see.
No cursor?
We have, sir. We can see.
The arrow?
Even if you
Yeah,
do the
yeah.
full screen, sir, you can go for a annotation. So you can even,
Hmm?
if you want to mark something, you can start the option of annotation.
Start what?
Annotation option is there. If you see, it's there.
Innovation.
ANNOATION.
Innovation. Innovate.
Annotation. Yeah.
Where does it come?
View,
You can
view
annotate.
options.
There must be options.
View options. Hmm. Doesn't show.
I think in slide sharing only it will show, sir.
Okay. Okay.
Share screen, where when you press share screen, you can annotate, I think. That ones.
Innovate. Right. Innovate and mouse.
Yeah.
Okay. Is it coming?
Not able to, not visible.
No. Leave it then. I'll just go like this. I think I'll do it without it.
It's fine, sir.
But why is
Whatever
it
you
not,
find feel comfortable with.
why is it not moving back?
You can stop sharing and then restart the sharing, sir,
Okay.
if you want.
But the mouse has stopped working completely.
Should I stop the sharing? I can do on your.
आप करो, स्टॉप शेयर कराओ दोबारा. अब ये तो चल पड़ा वैसे.
हाँ
अगर
चलो
ऐसे
कर लो
ठीक है तो ऐसे चलने दें.
यस सर चलो.
चलो ठीक है. So I must acknowledge the help given to me by my fellow Dr. Kush Luthra in preparing this presentation. So thank you, Kush. So when we are dealing with abdominal masses, ये पता नहीं ऊपर क्यों आ जाता है ये. So basically अगर etiology से देखें तो masses in children can be congenital or acquired. When you are talking of congenital, then a very simple division between solid and cystic, which is very important. And this division can be very easily made by a simple ultrasound examination, which is very frequently available everywhere. So if you have a congenital solid lesion, the differential diagnosis is very limited. Either it's a kidney tumor or a neuroblastoma or a teratoma. This will cover almost 90%. And we need not remember fancy diagnosis for our clinical purpose. So remember, a mass which is there since birth and is solid on ultrasound can either be of these three etiologies, and therefore this child needs a straight away a referral to a pediatric surgeon or a PHO center. If it's a cystic mass, then the story can be different. Cystic masses can have a differential diagnosis of a very long list. For example, ovarian cyst, which is commonest cystic swelling in a female neonate, and most of them are antenatally diagnosed. And postnatally, you don't have to do anything except follow it on ultrasound for its size. Most of them tend to decrease in size gradually, but if they stay beyond 5 centimeter, or if they cause pressure symptoms, for example, urinary symptoms, um, abdominal intestinal obstructive symptoms, or urinary obstructive symptoms, pain, in that situation, they need to be referred earlier. So other cysts can be mesenteric in origin, omental, duplication cyst of intestines, and choledochal cyst. Choledochal cyst is usually below the liver, but mind you, in a female child, choledochal cyst and ovarian cyst, very difficult to differentiate. Kidneys can also have cystic masses, but less common. And most common cystic swelling arising from the kidney, which can present as a mass, is hydronephrosis, simple hydronephrosis. And then very complex cysts like meconium disease, they can present with cystic disease, but usually at that diagnosis, the newborn is distended at the time of birth. Other cysts, he is not distended, he is not obstructed, but meconium cyst, the child will be distended at the time of birth and intestinal obstruction will be there. So it's very simple to pick up. Amongst the acquired masses, you can have inflammatory masses, as I have listed here. Most of them are either arising from appendicular abscesses or appendix masses, appendicitis which has not been treated surgically right at the onset. The child presents with abdominal pain, somebody suspects appendicitis, or even without suspicion, puts them on antibiotics, then antibioma develops, they form a phlegmonous mass, and they present a few days later as a mass in the abdomen. Similarly, tubercular masses, abscesses, hydrated cysts. But inflammatory masses, generally speaking, you will pick up because they will have other signs of inflammation, like acute onset pain, fever, tenderness to touch. They will not be able to walk properly. They will limp while walking. And therefore, it is not very difficult to pick up inflammatory masses in the abdomen in children. And then there can be traumatic masses. For example, somebody is bicycling and then he falls and there is a handlebar injury into the rectus abdominis, and it develops a hematoma in the rectus abdominis, which presents as a typical mass arising from the parietes itself, not intra-abdominal mass. And usually in such a situation, history is so clear, and therefore there is not much of a problem in diagnosing. Now, some of the congenital masses may not be picked up at the time of birth, and therefore they can also fall in the acquired category when the presentation comes late. And my focus today will be to pick up those masses and to refer them early, and the reasons for that I'll explain as I go along. So we know during undergraduation, this used to be a good mnemonic, that distended abdomen can have a differential diagnosis of fat, feces, fetus, fluid, fetus in fetu, and therefore we can exclude each one by one, clinical examination, ultrasound examination, and sometimes, as you would remember, the final examination viva used to be centered around differential diagnosis of abdominal distension, and this was a good mnemonic. But does it apply these days? Let us see. Now, when we are talking of infants, masses in infants, the flank masses, you can have a very clear distinction whether this mass is in the flank or in the center of the abdomen or in the iliac region. You would remember 9 different regions of the abdomen: epigastrium, hypogastrium, right and left iliac fossa, right and left hypochondrium, umbilical region, and lumbar regions. So when you're talking of flank masses, remember in infants, 65% masses. So majority of the masses will be in the flank, out of which majority are renal. And what can arise from the kidneys? If it is cystic, it is hydronephrosis or polycystic kidney. If it is solid, it is either a mesoblastic nephroma or Wilms tumor. Sometimes non-renal tumors can also be there, but they are very uncommon, like adrenal hemorrhage or a neuroblastoma or even a teratoma, retroperitoneal teratoma. But that differentiation is not very much important in your clinic. If you pick up a flank mass, then think of this differential diagnosis and think of further workup. Similarly, intraperitoneal masses, which form about 20%, they can have GI masses in 15% cases. For example, cystic masses of duplication, meconium disease, mesenteric cyst, omental cyst, hepatobiliary system like a choledochal cyst or a gallbladder cyst, and solid tumors of the liver like hemangioendothelioma and hepatoblastoma. So again and again, differentiation between solid and cystic will keep on coming. And ultrasound is the key investigation to tell you whether a given mass is solid or cystic. And then the pelvic masses. 15% of such masses are pelvis. Most common of them, either an ovarian cyst in a female or hydrometrocolpos because of a blocked vagina, or a sacrococcygeal tumor, teratoma, and pelvic neuroblastomas also fall in this category. When we come to adolescents and children, the ratio changes a little bit in the sense that flank masses take precedence over all other masses. And in this group, Wilms tumor stands alone as the most important differential diagnosis if you have a solid flank mass in a child. Of course, cystic will be hydronephrosis and other cystic diseases of the kidney. And then neuroblastoma, teratomas, and other neoplasms in the flank masses. Similarly, pelvic masses, teratomas, and rhabdomyosarcomas. In this group, in children and adolescents, solid tumors can be teratomas, pelvic neuroblastomas, or rhabdomyosarcomas. Rhabdomyosarcomas can also have presentation with limb masses, extremity masses, head and neck masses, chest wall masses, and several other differential diagnoses will come up if you are dealing with solid masses arising in the extremities. So just the basic stuff. Obviously, whenever you see any patient You start with history and age. As I said, neonatal will have congenital masses. A little infant, solid mass, think about cystic or solid kidney tumors like mesoblastic nephroma. Further up, like 3 years, 4 years, think about Wilms tumor and so on. And then the duration of mass, how did it start, any associated symptoms, history of trauma, then antenatal and birth history. It's very good to go through the antenatal scans to see if there was any indication of congenital swelling, and then usual features in the history, family history, especially to pick up syndromic association like Beckwith-Wiedemann syndrome, WAGR, Gardner, Men to be Bloom, several syndromes. Similarly, routine stuff in physical examination. I'll not go into the details. In the present context, when you're dealing with a mass in the abdomen, please do not do a very detailed examination. Do not palpate it again and again, because one, it disturbs the family and disturbs the child. It makes them irritable. And if it turns out to be a malignant mass, then examining the child again and again is not good for the tumor itself. These days, ultrasound has become a part of the clinical examination. So if the mother tells you, look, doctor, I've noticed a lump in his tummy for last 10 days or 15 days, otherwise the child is well, then just put your hand on the abdomen, gently palpate, but don't dig your fingers inside. Don't try to elicit those fancy signs which are described in books, and then send the child for an ultrasound. Of course, after doing a complete physical examination as far as the other systems is concerned and vitals is concerned. For example, say like other examination, look at the head and neck. For example, if a child has a flank mass and has a problem in the iris, then the diagnosis is virtually made. This is a Wilms tumor. Eyes can show you several features which will point towards a diagnosis. Eye swelling, neuroblastoma, proptosis, Horner syndrome will indicate sympathetic involvement, and facial dysmorphism, which will indicate a syndromic association. And then usual inspection, palpation, percussion, and auscultation in the abdomen, but be very limited and be gentle to the child. Don't over-examine the child. And don't forget the genital and perineal examination. Now, as far as a practicing pediatrician is concerned, when you come across an abdominal mass in a child, which is sort of incidentally picked up, then it's good to have a basic workup in the form of a blood count with differential count, a routine LFT and renal function test with amylase and lipase levels, urine routine levels, routine and microscopy. VMA and HVA can be done at a tertiary care center also if you suspect a neuroblastoma-like problem. Other investigations, alpha fetoprotein, beta SCG, LDH, uric acid, I think they're best left to the referral center because you have a package of all the investigations which can be done in a single pick. Imaging. When it comes to imaging, I'll advise you to just do a plain X-ray abdomen and a chest X-ray and an ultrasound examination. These are the three basic imaging investigations which you must carry out when you do a physical examination and when you pick up a mass in the abdomen of any child. Now, generally it's a tendency to order a CT scan or an MRI to delineate better anatomical features. I would advise not doing it in the routine practice, because most of the times when we see these patients who come to us after having gotten a CT or MRI, we generally have to repeat it, because the information that we want, at least from the surgical perspective, operability, involvement of other organs, vascular invasion, vascular encasement, ease of operation, other systems involvement, metastatic workup, then that information is wanting in most of the MRIs and CTs that are done from outside laboratories, partly because the labs who are doing these investigations are just doing the investigation without looking at the clinical picture of the child. without the surgeon being there, without the hemato-oncologist being there, without the team being there, without the tumor board being there. When we do the CT and MRI at our place, we have several other things. For example, we might order a CT angio if you suspect a Wilms tumor. We might order a CT angio of the abdomen as well as chest, because we have to see the lung metastasis, lung involvement in Wilms tumor. Similarly, we can have high resolution CTs, and CT can be tailored to the need of the patient. And then when it is done at a tertiary center, then we sit with the radiologist and discuss it and make out a plan for surgery or for preoperative chemotherapy. Now, if you have ordered a CT, then please get a CD from the CT center, which we can run in our center and then get more information. So a big question, when to refer? I'll not go into the detail of this flow chart. So let us talk about renal masses now, because renal masses form the most common etiology of masses in the abdomen in children. Now, many of these will be asymptomatic. The mother will come and tell you, doctor, I have noticed this fullness, I have noticed this lump while I was bathing this child this morning, and otherwise he is fine, his appetite is good, he is passing urine, he is passing stools, he is growing well, he is vaccinated, but this I have noticed only 2 days ago or today. And this mass is usually in the flank, as I said. You might ask the history of hematuria or hypertension, because hematuria and hypertension can suggest either a renal involvement, and hypertension can be there in neuroblastoma as well as Wilms tumor. Now remember, most flank masses which are solid are malignant. But even if they are malignant, they are curable. Remember that unlike adult malignancies, in children, the intent is always curative, even if it is stage 4. Now, why early referral may be important when you pick up a flank mass? Because many of these masses will be Wilms tumor within inverted commas, Wilms tumor family. So there are several variants of Wilms. Now, some of them, especially in infants, they are not malignant per se, but may require chemotherapy if the histology is a typical cellular type of histology. But in them, if they come to us early and we do a complete radical resection, then that alone can be curative, even if the histology is cellular. But completeness is important. So complete surgery can be done only when the child comes early, when the tumor is small. Remember, smaller the child, better is the chance of cure by early and radical surgery in these tumors. And I'll illustrate. So this is an infant who presented with left-sided flank mass, and we did the imaging and we found that this is operable. This was an infant. Now the differential diagnosis of a flank mass which is solid in an infant, the most common one is congenital mesoblastic nephroma. And if you do it complete excision, radical nephrectomy, then it can be curative without the need for any chemotherapy. And this is what we did. Now you can see the big mass, and here on the bottom left side, you see the tumor bed after excision. You can see the vertebral body, vertebral column, and over which you are seeing the aorta, which is laid bare. So radical excision is very important. Entire fat and fascia to the left of aorta has been excised. On the right hand side of this picture, you see the pancreas, the splenic vein, and the spleen, which are all saved. So how do we process renal masses in the pediatric hemato-oncology units, or when we work together with PHO teams, surgical teams, anesthesia, radiology? How do we process? So obviously when the child comes to us, we'll take a history and do a complete physical examination. And then we'll order some imaging investigations depending on the need for the patient. So these investigations are tailor-made. Ultrasound is almost always done, and then a CT with angio sequence. Because as a surgeon, one would want to know the vascular invasion, the vascular supply, the safety of resection, whether the tumor is going around the vessels, whether it is encasing the vessels, so that we can define the image defined risk factors. On imaging, we decide whether this mass is operable or not. On CT based imaging, we decide whether to go for a preoperative chemotherapy or go straight for an operation. And if it's a Wilms tumor group, then we do a CT chest as well in the same setting. And then in some situations, we take a needle core biopsy from the tumor, which again is image guided under sedation, and then decide whether or not to give preoperative chemotherapy. Most of our Wilms tumor patients will receive preoperative chemotherapy because either they are presenting to us with a large mass or they are inoperable at the time of initial presentation, or we just think that doing a preoperative chemotherapy might make the surgery easier after 4 cycles of chemotherapy and might prevent local recurrences. And once we start chemotherapy, then we reassess imaging after 4 cycles and then operate, do the histopathology, and then depending on that, we go for further completion of chemotherapy. So how have we improved the outcomes in these masses? It's because for every kind of mass, we have a protocolized management. And we do a quick review of imaging, blood work, and biopsy, and everything moves simultaneously. I get involved right from the beginning, like Manas Kalra, Dr. Anupam Sasdev, radiologist. We all get, when we go to the radiology, we discuss it together. An early start of chemotherapy. From the time of presentation, you will not believe sometimes we start chemotherapy the very next day because we have everything ready within 24 to 48 hours. So teamwork is right from the beginning is very important, which includes PHO team, surgeons, pathologists, radiologists, sometimes cardiac surgeons, as I'll explain. Tumor board. We have a tumor board which discusses each and every case of tumors in children. And of course, in the team, we always keep parents looped in and keep them informed all the time. I'll give this example, how teamwork is important. This 3-year-old girl from Odisha was referred to us for surgery because this complicated surgery was not available in Odisha. She had a right-sided Wilms tumor with extension into the right atrium along the inferior vena cava. So we involved the team of a pediatric surgeon, which was me, cardiac surgeon, Dr. Raja Joshi, PHO team, PCS ICU, pediatric ICU, and of course radiology for 3D reconstruction of the images. So this was the girl, and this was the imaging that we discussed. Without going into the details of this, the CT picked up that there was a tumor thrombus going from the renal vein through the IVC, through the liver, and then into the right atrium. And she had already received some chemotherapy. So we did a very complex operation on this child. As you can see, the chest is open higher up, and you can see these cannulas. The child is on bypass, cardiopulmonary bypass, and lower down, the abdomen is open. IVC is also cannulated for lower abdominal bypass, and we excise the tumor as well as the right atrial mass completely, the right atrial mass from above through the chest by the cardiac surgery team and abdominal from the pediatric surgical team. And just to create interest, this is the median sternotomy incision, and we are working on the heart just before doing the bypass. And this is the tumor bed and the tumor, excised tumor. As you can see, the tail of the tumor, which is going along the IVC into the right atrium. So this was a complete excision, and you can see the tumor bed. Both the aorta as well as the IVC are exposed, and the entire tumor is now removed. And this patient is now tumor-free and is completing her chemotherapy. So what are the benefits of early referral? Many parents delay surgery in small babies as they think that the child is too small, and the grandmom refuses surgery because the child is too small. Now, it's, as a primary pediatrician, it's your duty to guide them well, telling them that age is not a restriction. In fact, sooner they go for surgery or for definitive therapy, the better are the chances of cure. And early surgery and early treatment can prevent malignant transformation. And sometimes we can provide cure without chemotherapy, even when the lesion is a malignant one. Now, I'll give you more examples. For example, this was a child, 6 months old, who has a right-sided upper abdominal fullness, but no fever, and is otherwise asymptomatic, thriving quite well. And then on further workup, we found out that this child actually had an adrenal tumor from the right side. Now, adrenal gland is very deeply seated gland behind the liver. Therefore, adrenal masses may not be palpable. But if the mother has noticed some fullness, we must pay attention and at least get an ultrasound if clinically the mass is not palpable. It's a different matter that this tumor being reasonably big for a 6-month-old, the pediatrician in fact was able to palpate and sent him to us. Now, it is important for adrenal tumors, especially because the size of the tumor determines whether it is going to be malignant or benign. So if you remove them while they are small, they will still be benign. And resection alone is curative, no further chemotherapy. But if you wait and it grows, then it turns malignant, then it requires further therapy as well. And also the resection becomes difficult. Now, resection of adrenal masses in small children surgically is not a very difficult task, although it requires great amount of precision. As you can see here, the liver, hepatic veins, the renal veins, IVC, they are all in close proximity with the tumor. And you have to be careful and do surgery under magnification. But once done, it is curative with no after effects. And most of these surgeries do not even require blood transfusion. Now, when there is a tumor picked up in early infancy, which may be congenital, this is a good example. So this is a 1-month-old child, and the parents have noticed progressive epigastric distension with vomiting. And there's a firm mass felt in the epigastrium. So this is a 1-month-old child. And when we questioned the parents, they said, well, when he was born, he was full in the epigastrium, but we didn't pay much attention. Our pediatrician also thought it is usual for children to have a bloated tummy. But then it has never subsided and it is becoming bigger and bigger. And when I put my hand on it, it feels firm. So this is the information from the mother herself, which we of course confirm that yes, there is a mass and there is a solid mass on ultrasound. So this child, I'm just cutting short, ultimately had a teratoma arising from the stomach. As you can see in the lower left-hand side picture, the pink structure is the stomach, and the thing that I'm holding in my hand is the tumor, which is arising from the stomach. So we removed a portion of the stomach which was bearing the tumor, and complete excision was possible. And this on histology was a mature teratoma, and therefore no further therapy was required. And this surgery happened within 4 days of diagnosis. Another child is 2 weeks old. Same story, epigastric fullness since birth, vomiting, and firm epigastric mass. This child also had a gastric teratoma. As you can see, again completely excised along with a sliver of stomach. In the left-hand side picture, the yellow sling that you're seeing is the demarcation between the tumor and the stomach. So we remove kind of a partial gastrectomy, remove the tumor, and in this child, this tumor had involved left lobe of the liver as well. So he required a limited liver resection also. As in the middle picture, in the lower row, you can see I'm holding the portion of the liver which is attached with the tumor, and then you can see a staple line which is the partial gastrectomy. So again, even though this tumor had involvement of the liver, involvement of the stomach in the entire lesser curvature, yet it was a mature teratoma and therefore resection was curative. But this resection also happened within a week of presentation. So early surgery, early referral is important for congenital tumors. So a word about gastric teratomas. Gastric teratomas are germ cell tumors. They are usually congenital, but they can present later when they start enlarging. Most gastric teratomas are mature and therefore they do not require chemotherapy if completely excised. But delay in surgery can result in more mutilating surgery, extension of the tumor to surrounding organs, gastric resection risk, and the risk of recurrence. Now, when you're talking of teratomas, usually teratomas are in the central abdomen. So apart from gastric teratomas, you can have retroperitoneal teratomas also, which grow to a big size and come to lie and show in the epigastrium or in the umbilical region. So midline tumors, think about teratoma. Flank tumors, think about kidney tumors. Cystic tumors, think about hydronephrosis in the flank. Cystic tumor in the center of the abdomen, think about duplication cyst, mesenteric cyst, ovarian cyst, choledochal cyst. So now let us come to neuroblastoma. Neuroblastomas again are very common tumors. The differential diagnosis clinically may be difficult from renal masses, such as Wilms tumor. But in neuroblastoma, the patients are generally more sick. Unlike Wilms tumor, where the mother will say, I've noticed this mass this morning, the neuroblastoma patient, the parents will say, well, this child is not well for last several weeks. Sometimes he develops fever, he doesn't eat well, he is very irritable, he is not gaining weight, rather he is losing weight. And sometimes he says there is a pain in the limb, sometimes there is pain in the back. So he's generally not well. And I can feel some fullness in his tummy. So they have constitutional symptoms. And when you put your hand on the abdomen, you immediately get a feel of a very, very firm, very irregular, bossulated surface, fixed masses, and they may have fever. So again, management of neuroblastoma requires a perfect teamwork because diagnostics can extend from doing scans, ultrasound, CTs, MRIs, even more elaborate scans, MIBG scans and things like that, and a urinary workup for urinary catecholamines, bone marrow, and of course, different sorts of imaging. And then biopsy is a very important aspect of neuroblastoma management because then chemotherapy is specifically directed for a particular histopathology. And then chemotherapy. More often than not, neuroblastomas will receive chemotherapy first and then resection if possible. And neuroblastomas are a very wide variety of tumors, and the management of neuroblastoma is a very, very large topic. As a surgeon, we come into the picture when the child has been diagnosed, has been given preoperative chemotherapy, and repeat imaging has been done. Then we discuss that imaging to see the operability. One of the characteristic features of neuroblastoma is on imaging, they tend to invade blood vessels. They tend to surround blood vessels. And that is why their surgery is more difficult, more demanding. So this is an example of a neuroblastoma, a very big mass. And the imaging, you can see the CT scan picture showing a very large mass crossing the midline. You can see that it's lying anterior to the kidney and it is crossing the midline. But then again, we were able to resect this mass completely after giving 6 cycles of chemotherapy, which Manas Kalra gave very effectively. Now there is another spectrum of neuroblastoma, which is the benign end of spectrum, which forms these entities: ganglioneuroma, ganglioneuroblastoma, paraganglioma. So they are less severe varieties of neuroblastoma. They are not as high risk as the other neuroblastomas. I'll illustrate. Now this is a girl whom we operated last week only. So this is a 4-year-old girl who was presented with this swelling in the lower abdomen and the hypogastric region. And when you try to feel this swelling, I was unable to feel the lower end of the swelling. So when you are unable to feel the lower end of the mass, then it is arising from the pelvis. Now, when a mass is arising from the pelvis, in a female child, you start thinking of ovarian masses. You start thinking of sacral masses coming off from the anterior sacral wall, and you start thinking of masses coming from adnexal structures. So obviously this was a solid mass on ultrasound. So on imaging, it suggested that the tumor is attached to the anterior sacrum and it has a tendency to go into the sacral foramina. So the moment you see something going into the sacral foramina or intervertebral foramina, you think of a tumor of neuroblastoma family, a neurogenic tumor coming from the paravertebral sympathetic chain or paravertebral ganglia. So this child had a PET scan, because in such situation, PET scan is important to see FDG avid activity elsewhere also in the body. So that's a part of the metastatic workup. And this child had this FDG avid mass in the pelvis, but the FDG avidity was not very much, and there was no other area of activity. And then we did a biopsy on this child, and biopsy confirmed that this was a ganglioneuroma. So here we are, a neurogenic tumor, which is ganglioneuroma on biopsy, and is involving the sacral nerve roots. So what do? This tumor is not going to respond to chemotherapy. In fact, the chemotherapy is not required. And therefore, we went straight for excision. Excision in such tumors can be a very difficult task. As you can see on the right-hand side picture, the ureter and the iliac vessels are stretched over the tumor. So you have to resect the tumor, saving the important vascular structures, ureter, and everything else. And on the left-hand side picture, you can see these bossulations in the picture. They are actually extensions of the tumor into the neural foramina of the sacrum. We have excised it completely, and the histology is still awaited. And we will then decide about the future course of treatment depending on the histology. Now, even if the preoperative biopsy was ganglioneuroma, it's not a guarantee that other areas of the tumor will not have a neuroblastoma-like picture. And therefore, the need for chemotherapy will be decided finally on the histopathological examination that will come in a few days' time. Now, this is the example of a newborn who had come with an antenatal diagnosis of a cyst in the pelvis or in the right-sided right iliac fossa. This is a female child. In a female child, a congenitally detected cystic lesion is ovarian cyst unless proved otherwise. And this is the typical ultrasound finding. You can see a large fluid-filled structure along with ovarian follicles at the periphery. And this is almost kind of sine qua non of ovarian cyst in an infant. Management, don't jump at doing anything. Most of these ovarian cysts in newborn girls tend to decrease in size gradually, and you don't have to do anything. Only and only if the size increases or they produce pressure symptoms, we need to treat them. Treatment also is very simple. We do a laparoscopy and aspirate these cysts, laparoscopic aspiration, and that can be curative in many. If not, then you could do a deroofing, again laparoscopically. So the surgery for ovarian cyst is quite simple. One of the things about ovarian cyst is sometimes they can undergo torsion. There was a slide. Yeah. So sometimes they can undergo torsion. Say, for example, this. And how you find that this cyst has undergone torsion there. We have done a laparoscopic dissection in most of the part, but to take it out, we had to do a small incision. Now, I'll take you through, just to create interest, through some of the rare things. For example, this 6-year-old girl came with an again epigastric mass, long-standing epigastric mass. And there was no history suggestive of any behavioral disorder, but she had this large trichobezoar within the stomach, taking up the shape of the stomach. And once in a while, you will still see such things who present as abdominal masses. Surgery is curative in these cases, but these children also need psychological assessment, because sometimes they have this psychological or psychiatric disorder of eating their hair, which needs to be addressed. Otherwise, recurrence is quite common. Now, I'll show you some examples which will illustrate why genital and perineal examination is important when you're dealing with a mass in the abdomen. So this infant girl came with a fullness in the lower abdomen. She was fine at the time of birth and remained so for the first 5 months till she was on the breast milk. Currently, she was not feeding well, but abdominal distension was increasing. And mass also was increasing in size. When we examined, there was an ill-defined lump in the left iliac fossa. Ill-defined lump, left iliac fossa. So what are the things that are coming to your mind? Obviously, there is a mass, and this is not a cystic mass. It doesn't feel like a cyst. There might be a tumor because the child has loss of appetite. And then we look at the perineum, and she has an anal stenosis. Now, first 5 months, this child was asymptomatic because this tiny opening of the anus located within the vulva was enough to allow passage of liquidy stools, which the child used to pass while being on mother's milk. And when weaning foods were started, she started having constipation and she found it difficult to pass, and therefore she developed fecal retention. And the mass that we were feeling was actually fecal matter. So if you do the perineal examination and look for the anal orifice, the diagnosis is established. And we've seen this kind of presentation quite often. Recently, we had a child who is 10 years old who had a lower abdominal mass, which was again because of fecal retention. And under anesthesia, we removed 7 kilos of fecal matter. So abdominal mass can really be feces also. One really has to see how things are at the bottom. And this child that I'm talking about, 10-year-old girl who had 7 kilos of fecal matter contained within her dilated rectum, because of that, she had developed urinary problems also. She had developed neurogenic bladder. And without naming, I can tell you, a very big hospital in Delhi had advised urodynamic study and Botox injection for her bladder symptoms without ever examining the child. So this is very important to consider the diagnosis of constipation with fecal retention, especially in the current scenario. Another example, a 6-day-old female child had a low abdominal swelling, which was increasing day by day. She had difficulty in urination, which was worsening. Initially, the urination was fine. Then gradually she started developing urinary symptoms and they kept on worsening. It came to virtual dribbling of urine all the time. So you'll tend to think that, yes, this child seems to have some urinary retention or a bladder problem. And she's just 6 days old. And then we look at the bottom. So These are two children. The picture above shows a bulge in the vulva, which was because of an imperforate hymen, which led to hydrometropalpos. So the vagina got distended, the uterus got distended, they pressed on the bladder. So she had that mass appearing because of collection of fluid in the hydrometropalpos, and the urinary symptoms were because of the pressure on the bladder. The lower picture shows a very rare cause of urinary retention because of a urethral polyp. So you can see this big polyp-like structure which is coming out of the urethra. It keeps on coming out and going in and produces obstructive symptoms. So the idea of giving these examples is just to highlight that a simple look at the genital area and the perineum can be of great help in making a diagnosis. And this should not be overlooked. We generally have developed a tendency these days not to examine our children, not to put our hands on the tummy, just ask the history, see the reports, see ultrasound, see CT imaging, and then decide treatment. Please do examine, put your hand on the tummy, examine the genitalia. It will help you pick up many conditions which others may fail. Yet another example, a 6-month-old child who has a lower abdominal mass, again gradually increasing in size, difficulty in urination and stooling, and abnormal genitalia. The parent says that the genitalia is abnormal. Well, when the parent says the genitalia is abnormal, you will obviously have a look at it. And this is the child. So sometimes you can have very, very rare things presenting to you as abdominal masses. Now this child has got everything into double. So there are two phalluses, two scrotal sacs, and in the perineum you can see a bulge. He had two anal orifices, and both of them were stenosed. So the mass that we were feeling is fecal retention, and part of it is a presacral mass, which is partly showing in the perineum and partly reaching the abdomen. So very complex etiology, but the mere look at the genitalia will guide you that this child needs to be seen by a specialist. I've dealt with this cyst of the ovary, which is twisted. So I think I will stop here, and it's almost about 1 hour since we started, and I'll be very happy to take questions if there are any.
Thank you, Dr. Agrawal sir, for a nice, informative, and an eye-opening presentations. And definitely, we were missing a lot of things before your talk, and will be more educated after your talk. I don't think there are some questions. I think I request the audience to put the question into question and answer, and we can take you live.
I just wanted to ask one question.
Yes, ma'am.
How frequently we get a child with a urachal cyst? What is the usual presentation and incidence of this? Because I had a child a day before yesterday. The child was, I think, around 10 years old. He just presented with pain in abdomen, and basically pain was on the left iliac fossa, and there was no lump palpable as such, no history of constipation, nothing like that. He had similar complaints 6 months back also.
All right.
And I
And how
thought
did
I
you,
should get an ultrasound done. First of all, I was thinking about a renal polyp, which is very common scenario in this area. But ultrasound was suggestive of a urachal cyst, urachus. So obviously, I advised him to go to a pediatric surgeon for further management.
right?
But sir, just wanted to know because at this age we never suspect urachal cyst with this presentation,
Fine.
and that was around 2 centimeter in size. It was not palpable per abdominally.
Sure.
तो पेरेंट्स जो थे सर वो भी कन्विंस नहीं थे उसकी मतलब जब उनको बताया गया ये प्रॉब्लम इवन आई वाज नॉट सस्पेक्टिंग.
This is quite a common scenario. In
Okay.
fact, the urachal abnormalities, let us put it urachal abnormalities, they can fall into a patent urachus which will obviously manifest as urinary leak through the umbilicus, which of course is not there in this case. Then patent urachus towards the bladder with a closed urachal remnant, which will act like a diverticulum from the bladder. Now, if you look at the etiology and embryology, the urachus remains patent if there is a blockage in the distal urinary passage or there is a pressure in the bladder, which leaves the fetal urachus still patent. This is one of the pop-off mechanisms to take away the pressure from the bladder so that the pressure in the bladder does not reach the kidneys. Now, urachal prominence is very common. Most of the time it remains undetected if there is no distal obstruction. But it can become symptomatic in the form of pain if there is an infection in the urachal cyst, and then it becomes a urachal abscess. If it's an abscess, the child will have all acute symptoms, acute inflammatory signs, redness on the anterior abdominal wall, etc., etc. And the management is also very simple. You give antibiotics. If it doesn't subside, you may do an incision and drainage. And usually that is enough. It doesn't cause recurrence because all the urothelium that is there gets burnt out in the infective process. But diagnosing them on ultrasound and then stopping there is not wise. You must do urinary tract evaluation, especially this child is presented with a left-sided flank pain. So a girl child with urachal remnant being there must look for urinary infection and very clear, the ultrasound should be very clearly showing the left kidney, which is normal. Uretroceles and urinary reflux in female children and UTI is quite common, and their presentation may be with the help of with the form of a urachal abnormality. So one would tend to do an ultrasound to show the pre and post void residue. How much urine is there in the bladder before she voided, and then how much urine stays after she is voided. That is very important.
So that was a male child actually, not a female child.
Male children, again, that is even more important because male children with urachal abnormalities can have distal urethral obstruction. So MCUG will be of help in this child before we embark upon treating the urachal cyst. Treatment is very simple. You do a laparoscopy and excise it. Very simple.
Yes.
But you must rule out distal obstruction if you have a urachal abnormality.
Yes, sir. It's
So
always
if you permit me,
yeah.
can I stop the sharing the screen
Oh, yes.
for the better visual? Yeah. Now, Dr. Pankaj Garg want to ask some question.
Hello, Dr. Satish. Welcome
Hello,
to the.
Pankaj, how are you?
Yeah. First of all, welcome to the IAP North Delhi meeting because I am part of IAP North Delhi and being a part of Gangaram Hospital.
Great.
We are very proud to have you in our Gangaram Hospital team.
And you would remember both these gastric teratomas, you were the one who handled them in your nursery. They were so small.
So thank you so much for this excellent talk. I think a team of a multidisciplinary team, which is the principal of Gangaram Hospital, has helped many of these cases as a collective wisdom, and we have done good in most of these cases. So as a pediatrician and as a follow-up person who sees patients, my one comment is that examination of abdomen in a child, especially young infant till 3, 4, 5 years of age, may be a very tricky thing. Many babies, many parents come to us with abdominal fullness, and examining a crying child or uncomfortable child, it's extremely important that we have to make the child comfortable. So what I always recommend is that whenever a parent is saying that the child has some abdominal fullness, it's important that the child is either sleeping or you make them wait and the mother breastfeeds and then the child is quiet. So examine the baby in mother's lap, because otherwise if you make the baby lie down on the bed, especially this child less than 3 to 4 years, they cry so much, the abdomen becomes tense, you're not able to palpate anything, and then you say yes, there is abdominal distension, then you are trapped. If you say no, there's no abdominal distension, you are trapped. So examination properly is one thing which is a pediatrician's domain, so we should emphasize that. Second, I think very, very rightly said that retained stool, somehow constipation is so rampant these days. Every third, fourth child which we see in our OPD practices is constipated, and they do come with the same symptom. The child's abdomen is full. and we have to examine properly that child also with a history of constipation. I've seen people advise ultrasound very, very often. So I will see that getting an X-ray may be a little better if you're suspecting constipation. That also tells us what is the extent of the problem. But I think most important is that to keep it in your mind that constipation is a common cause, but it does not mean other masses cannot exist in children, and we have to examine a number of times before we say that there is nothing abnormal with the child, especially if the child is coming with these symptoms. Thank you so much, Dr. Satish, for your.
I think Pankaj, you have touched a very, very important point as far as clinical examination is concerned. There is no second thought about it that examining a crying child is next to impossible. You cannot elicit anything in a crying child. And examining mother's lap is a wonderful idea. We keep doing it every day. In fact, if you remember the IHPS, the congenital hypertrophic pyloric stenosis,
Yeah, absolutely. Yeah.
the technique of being able to palpate the olive is when the mother is breastfeeding the child.
Absolutely.
Position in such a way. And as far as constipation is concerned, I fully agree with you. Constipation is so rampant. But I'll give you a very clear example how a patient was diagnosed as Hirschsprung's disease because he presented with constipation but had something else. And this was a 6-month-old child who had progressive constipation. They used enemas, they used suppositories, and yet it was not going away. Nobody had done a clinical examination on this child. When they came to me at 6 months of age, that was when I was at MAMC. I just did a rectal examination, and there was a big presacral mass, which was a cystic presacral teratoma. So this child was almost getting ready for a rectal biopsy somewhere and then followed by a pull-through procedure, because clinical basis they diagnose Hirschsprung because the constipation is not resolving. So a proper examination. Rectal examination sometimes is very important. Most of the times it is not required, but the clinical scenario should dictate whether it is needed or not.
Absolutely, sir. And neuroblastoma, I think one thing which is very important, that if you diagnose in newborn period, they may vanish also. So I've seen a couple of cases in newborn period, antenatally suspected, diagnosed in newborn period. There is that special variety of neonatal neuroblastoma, and then it may go away without treatment also. I think a comment from your side.
I think Manas will be better to comment on that, but we have seen umpteen number of congenital neuroblastomas which have done very well. In fact, one of the prognostic factors in neuroblastoma is age. The younger the patient, the better is the prognosis.
You are right, sir. So stage 4S neuroblastoma that we see in very young children, less than 18 months. So they usually have very small neuroblastoma. They may have hepatomegaly. They may have skin nodules. And usually they do not have any bony metastasis, and the bone marrow metastasis, if there, is very less. These neuroblastomas can resolve spontaneously. Sometimes they need very minimal treatment, very minimal chemotherapy, and they are fine. Thank you, Dr. Satish, for a wonderful talk. I just wanted to add a couple of things. That one important investigation is alpha fetoprotein and beta HCG level in patients with germ cell tumors. You have already mentioned that. So sometimes just doing a blood level of a simple test like alpha fetoprotein or beta HCG helps you to tell that the abdominal mass can be a germ cell tumor. Hepatomegaly, if you have a hepatic mass and your alpha fetoprotein is very high, then usually the diagnosis is hepatoblastoma. So that is another thing for our pediatricians. And always we need to look at the age-related cutoff for the AFP, because in children normally also AFP is very high. In newborns, it is very extremely high. So we have to look at the cutoff and then see whether this alpha fetoprotein is high or not. So it is helpful in germ cell tumors and also in hepatic masses. Another important thing I wanted to say was that sometimes these renal masses, when they come to us, you have a malignant looking renal mass. Nowadays, a lot of recommendations are there to not do a renal biopsy. So, this question will come to the pediatrician, because, you are sending a patient to us. The child has a renal mass and we start immediately with chemotherapy. then you may say कि भाई ये तुम इसको मैनेज कर रहे हो कैंसर की तरह, मगर इसका तो बायोप्सी नहीं हुआ, आपको कैसे पता कि ये कैंसर है या नहीं है? So a lot of, there is a lot of literature which says that if you have a renal mass and it looks cancerous, looks like Wilms tumor, you give chemotherapy, shrink it, and then the surgeon will remove the tumor, and then the mass will show a Wilms tumor, and more than 99% of the times you are going to be correct, and this avoids a biopsy and avoids an upstaging of the disease. So we usually take our pediatricians into confidence. We explain to them that why we are going ahead with chemotherapy and not doing a biopsy for these masses, and then make the job easy for the surgeon. And then within 4 to 6 weeks the surgeon operates, and sir has shown many tumors that he has operated upon, and we have had fantastic results managing Wilms and other malignant solid renal and other abdominal masses. Thank you.
Thank you, Manas. In fact, this point is very important of biopsy or no biopsy. In fact, worldwide, there is a debate. The American group thinks something else, the European group thinks something else. And we have taken in India the best from both worlds. For an infant, if it's a kidney tumor, if it's a kidney tumor and is operable, I am more comfortable, and Manas agrees with me, that if we operate, it is likely to be congenital mesoblastic nephroma, for which surgery is curative, and we may not need any chemotherapy whatsoever. So there are pros and cons of doing a preoperative biopsy. Unnecessarily, if the image-defined risk factors are not there, child is an infant, and clinically and radiologically we can suspect mesoblastic nephroma. We have fantastic radiologists who can pinpointedly say that this looks like a Wilms tumor. The child that we showed, the one we did with cardiac surgeons, this child had a clear cell sarcoma of the kidney. And because biopsy had been done, we knew that this is a rare tumor. It does not respond so well to chemotherapy, and therefore we have to do surgery at some stage, even though its response to chemotherapy is not so good. So we have one end where the response to chemotherapy is also not good because we have done a biopsy and we know about it. On the other end of the spectrum, we have patients where we do not do any biopsy and take them up for surgery straight away. So it's a big spectrum. And that is why team effort is important. That is why we need to discuss in tumor board whether to go for chemotherapy upfront or to go for surgery upfront. So that's a very important discussion. Thank you, Manas.
So I don't think there are more questions. So thank you, sir. Thank you, Dr. Satish, for a wonderful presentation. Thank you, Dr. Pankaj and Dr. Manas, for valuable inputs also. Over to Dr. Shalini, if you want to say something.
I just want to say thanks to Dr. Satish, Dr. Manas for arranging this meet, and this was really wonderful and eye-opener for all of us. So your last case was very interesting. Never saw and never imagined such a deformity. So what have you done in that case? Double phallus and double scrot.
We have several such interesting cases. Recently, we had 2 cases of triplication of ureters. Recently, in fact, last week only, we did a case where there are 2 rectums, 2 colons, 2 vaginae, 2 uteri, 2 bladders, and 2 urethrae. So the management is tailor-made for each child. And as I said, anatomy can be delineated only when I am working with the radiologist. That is why I say imaging should not be done at a peripheral center. These days, diagnostic centers have come up every nook and corner of the city. Most of the times, if you get an MRI or CT from there, they do not give you the information that you require. It's not their fault. They do not have the clinical information. So we have started doing this program in our radiology department. But I or my team members go to the radiology. We'll cannulate the tubes, different openings. We'll put some saline for MRI. We'll put some dye if that's a CT. And we try to do imaging in such a way that we can pick up the anatomical features very, very correctly. And then we supplement it with an examination under anesthesia and endoscopy. So it took me more than 45 minutes to elucidate what is wrong with this child. There's a girl child from Meerut. And we have now sorted out a plan. We will make her into one anal orifice at the normal site. We leave her urethra as two. We leave her vagina as two in the beginning, and then we'll join them at the bottom so that she can have one vagina for sexual intercourse later in the life. So the management of each child is tailor-made. This particular child that you are talking about, this child had syndromic features. So we resected one of the phalluses because it was not connected to a bladder. We excised the mass. We repaired his penoscrotal transposition, brought his penis above the scrotum, and did some plastic reconstruction work. And inside, he had double colons. So we joined the two together and made it into one. So it was a staged reconstructive surgery.
Yes, so very interesting. Oh, thank you, sir. I think now, Dr. Dinesh, you want to say something?
Thank you very much, sir. Sir, just I had a question because this is a COVID time and no webinar can be completed without a question on COVID. So, is there any correlation with the intussusception and COVID? Because last week I had a kid, a 9-year-old girl who was COVID positive and persistent abdomen pain, transient abdomen, and on ultrasound she was diagnosed as transient intussusception. So, transient intussusception may be a normal finding also, but I just out of a curiosity, I just want to know: is there any correlation or any literature on it?
Well, now that you have raised this point, it makes me think, is there actually a correlation? Because recently we've had a spurt of interceptions. In last 3 or 4 weeks, we have seen as many cases. Three, I have seen, one of my colleagues also has seen one. One of them required a laparotomy to reduce. But then all these 4 patients were COVID negative because the policy at Gangaram is to do a COVID RT-PCR before admitting. So they were COVID negative. I do not know about COVID positive because they don't come to me as surgeon. Transient intussusception is a very common phenomenon,
Is a common phenomenon.
which is the ilioileal or jejno-ileal that doesn't require any treatment. But it's possible. I don't know.
Okay, sir. I think
Then
Dr.
thank you
Pankaj
so
want to
much,
say something.
Dr. Dinesh and Dr. Shalini and Pankaj and Manas and the entire IAP group in the North Delhi. I actually belong to North Delhi. I have a house in Janakpuri. My childhood was spent in Janakpuri. So I have a special attachment to North Delhi. So thank you again for giving me this opportunity. It was wonderful opportunity. Thank you
Dr.
so much.
Pankaj, you want to say something? I think
I
he has
just
raised.
I just wanted to say what Dr. Satish already said, that transient interception is so commonly seen now in ultrasound era that every interception which ultrasound is diagnosed, maybe only 1/7 of that will be requiring some treatment. I think this was also seen in the study that the Gagandeep Kang study on rotavirus vaccine, when they were following all children who were coming to them with pain abdomen after rotavirus vaccine, and they did see much more interception which were ultrasound diagnosed than which were clinically applicable, clinically diagnosed and required some intervention. So what Dr.
But
Satish
that
is saying
child
that
was severely symptomatic, sir.
yeah,
That
yeah,
is why
I'm
I.
not saying that. Yeah, I'm not saying correlation between COVID, but what I'm saying is ultrasound diagnosis is much more than clinical diagnosis or a diagnosis which requires some intervention. Ultrasounds, they diagnose maybe in acute phase of gastroenteritis. You do an ultrasound, they will tell you there is some interception, but that is usually transient. Definitely, a surgical need will be required. Just a comment, nothing else. Thank you.
Okay, sir. So thank you everyone for your patient listening and for your kind information. All these webinars are available on our YouTube channels also. That is www.youtube.com/IAP North Delhi TV. So if you missed some part of it or if you want to revisit this webinar, you can visit our webinar, this YouTube channel, and you can have a look on it. Most likely this webinar will be available from tomorrow onwards because some time, processing time is also needed. So
Yes.
with this point, we take a leave for next Wednesday, and thank you very much. Thank you, Dr. Satish sir. Thank you, Dr.
Thank you.
Manas and Dr. Pankaj.
Okay, bye-bye. See you next week. Bye.
Thank you. Bye-bye.
Thank you. Thank you. Bye.